All right, welcome and good morning to the first installment of the EIM Research Learning Collaborative, or the EIM RLC for short. My name is Mark Stoutenberg and I will be your host for today's event. In addition to serving as an associate professor and chair of the Department of Kinesiology at Temple University, I have served as a consultant to EIM for the past 7.5 years. One of my new roles is to help guide the future development of this EIM RLC, and I look forward to interacting with many of you as we move forward with this exciting new program. The idea for the RLC was born from a research summit of ACSM leaders in San Diego, California in January 2020. The goal of the summit was to examine the current level of evidence for the widespread adoption and implementation of EIM in health systems across the country. One of the end results of the meeting was that we have more questions than answers. We realized that there was a pressing need to engage and support a wider range of individuals interested in doing research related to assessing and promoting physical activity as a standard in clinical care, connecting patients with evidence-based physical activity resources for people everywhere of all abilities. Therefore, the mission of this EIM RLC is to bring together peers, such as yourselves, to learn, share, and apply best practices from the academic research community, combined with the wisdom of frontline service providers and exercise professionals in the field, to document and disseminate best practices for integrating physical activity into diverse health systems. When we first came up with the idea for the RLC, our goal was to engage 50 individuals. Today, we have more than 210 people signed up to our listserv, with more than 100 people registered for today's event. Clearly, there's a widespread interest and excitement for conducting EIM-related research, and we hope that you find the RLC to be a meaningful use of your time. A few notes about today's agenda. In just a few moments, I will be turning things over to Robin Stewart, Vice President of Exercises Medicine, for her opening remarks and a brief introduction to the EIM initiative. We will then turn the rest of this meeting over to Dr. Paul Estabrooks for his presentation, followed by a Q&A session. Please note that we have muted everyone on the call to block out background noise. We will proceed through both Robin's and Paul's presentations in their entirety, leaving all questions and discussion points to the Q&A time. We strongly encourage you all to use the chat box to post questions and comments throughout the presentations, which I will refer back to in facilitating the Q&A session at the end. So without further ado, I'd like to turn things over to Robin Stewart, our Vice President and leader of EIM.
Thank you, Mark. So I want to make sure that we're all on the same page when it comes to the Exercises Medicine Global Health Initiative. And because you're on this call, I know that you're a believer in the undisputable health benefits of regular physical activity. And there is extensive evidence in the literature as to both the chronic and acute effects of physical activity. And these were all documented in the 2018 Advisory Committee Scientific Report that formed the basis for the 2018 Physical Activity Guidelines. But Exercises Medicine takes this all one step further. Not only do we recognize the benefits of physical activity, but we believe, and our mission is that physical activity assessment and promotion should be a standard in clinical care because of the powerful mental health and physical health benefits. And connecting healthcare with evidence-based physical activity resources for people everywhere and of all abilities. That is the vision and mission of the Exercises Medicine Initiative. So we want to take that science and now put it into standard practice in the clinical setting. And we propose aligning exercises medicine with the SBIRT model, which is screening, brief intervention, and referral to treatment, which was developed as a result of an Institute of Medicine recommendation that called for community-based screening for health risk behaviors. And they started this out with substance abuse as their first behavior, but it's a comprehensive, integrated public health approach to the delivery of early intervention and treatment services, including lifestyle behaviors. So Exercises Medicine has three basic components to it. The first is routine physical activity assessment and screening within the clinical space. The second is that the patient is provided with brief advice, counseling, or a physical activity prescription that the patient can then fill either in community-based resources, which might include programs, exercise professionals, places where the individual can be active, or resources that are affiliated with a health system, for example, a medical fitness facility, or perhaps cardiac rehabilitation, or as well as self-guided resources that may allow the individual to, such as mobile apps or websites, that may allow the individual to be successful in identifying places in their community, whether it's their living room or it's a park or a neighborhood where they can be physically active. Just want to point out the Exercises Medicine website here, where you can find resources, action guides, templates, and prescription forms and patient handouts for healthcare providers, as well as guides and those handouts for exercise professionals that could be used within research to test various components of this system. And this is what we're recommending, and which we hope to see. It has to happen for Exercises Medicine to really come to fruition, and that is a systems approach. That there are structural and policy changes that affect healthcare and healthcare professional education that mean that it doesn't rely on just one provider or one exercise professional, but rather the system is built to integrate physical activity. And so that includes the electronic health record, because that is an integral part of healthcare these days. Including the physical activity vital sign, integrated order sets, referral and communication pathways that are smooth and easy to use. And we believe that when the healthcare system makes a commitment and builds partnerships with entities either within or outside the healthcare system, that they build that big bridge of trust to community-based fitness resources that make it easy for this to happen. So how can we convince key decision makers? Well, as Mark mentioned, there were many research questions that arose at the Research Agenda workshop. And we hope that we need more research to happen, identifying effective physical activity interventions that will achieve the desired health outcomes, as well as contain healthcare costs. And we want also research identifying physical activity interventions that are based within the clinical space that are scalable, adaptable, and cost-effective. And potentially research illustrating the cost to a healthcare system if they do not pay attention to physical activity, and they have many patients that they care for and pay for that are insufficiently active. So we are hoping that you all will design studies, try them, refine them, prove, and shed further light on how we can best integrate physical activity within the healthcare system and build those bridges so that patients can become more active and more healthy. So I am going to stop and toss this over to Dr. Estabrooks. And we are so thrilled that Dr. Estabrooks is joining us today. I don't have your bio in front of me, Dr. Estabrooks, but he is a pioneer and a leader in implementation and dissemination science. And Paul, if you can either introduce yourself briefly, or potentially Mark will do that, and we will get started with the substance of this workshop.
Yeah, Robin, I'll take that while Paul's pulling up his presentation. And thank you for that excellent overview to get us started. So with that foundation in mind, I'd like to introduce Dr. Paul Estabrooks to speak on evaluating the implementation of physical activity in health settings. Dr. Estabrooks is a distinguished chair of the Department of Health Promotion at the University of Nebraska, Omaha. He's a multi-funded expert in implementation science, studying the process of moving health promotion evidence into community and clinical action through integrated research practice partnerships to improve system-level support for physical activity promotion, healthful eating, and weight control. Dr. Estabrooks, thank you for agreeing to join us today, and the floor is all yours.
You're on mute, Dr. Estabrooks.
There we go. I am now unmuted. Well, thank you for that introduction, both Rob and Mark. I'll give one small correction. There is a University of Nebraska at Omaha. There's also the University of Nebraska Medical Center, and I'm at the Medical Center, which is just down the road, but we do a lot of collaborative work, so no worries on that. So yeah, I get the exciting opportunity to be your first speaker for your learning collaborative, and I get the very exciting topic of evaluation, which everyone's always thrilled to hear about. But I'm going to go into a little bit of evaluation, or not a little bit, a lot of evaluation, but I'm also going to talk just a touch about how you might be considering these evaluation outcomes during your planning process as well, so that you're making sure that you're getting yourself to a place where you can have a really broad impact with your exercises medicine work. I'm going to talk through the REAIM framework, and looking through the list of people that are on here, I recognize some names and know that some people know this pretty well. So for you, have any questions you'd like for me, but we'll try and get through this quickly. For those who haven't heard about it, I'm going to go through some definitions and methods that you might use to employ the REAIM framework when you're doing an evaluation of exercises medicine. So when you think about REAIM, I haven't said much about what each one of the things are, but the basic goal for planning and evaluation when we use this framework is, as you can see on the screen, to develop, so that's around the planning, and test, which would be around evaluation, health promotion, and programs, policies, and practices that can be adopted across a variety of settings, as well as by a variety of different staff levels, can be sustained with consistent implementation at a reasonable cost within whatever setting that it is, reach a large number of people, especially those who could benefit most and who experience health disparities, and then produce replicable and long-lasting improvements in health, or in this case, physical activity and the related health outcomes. So like I promised, we're going to go through fairly quickly some definitional pieces, and I'll just give you some examples from some of our previous work. So when we talk about REAIM, the first dimension of REAIM is reach, and that's the number percent of the target audience or intended audience, and the representativeness of those people who participate in your program or are exposed to an intervention. And so that's important to think about, both participating and exposed to. When we think about exercises medicine, you really need to be planning related to the proportion of your audience that's exposed to your screening, and the proportion that actually ends up getting brief counseling, and the proportion that actually ends up being referred to treatment, and then maybe even go as far as looking at the proportion that end up engaging with a community or clinical program that is there to try and help people improve their physical activity. You can see an example here from one of our studies that we did at Kaiser Permanente a number of years ago. It was a physical activity program integrated into primary care. And you can see our example here is the intended audience were inactive or insufficiently active people who were attending a well visit. You can see that over the time that we did this study, we had about 1,500 folks that came through those well visits. About 607 of them were eligible, meaning that they were screened for physical activity and were either insufficiently active or inactive. And then we got about 218 of those referred. So we did pretty well with screening, but the referral there wasn't quite as strong of follow through on referral. And so then when we look at the number of eligible that agreed to participate, we got about almost a little bit over half of those folks, about 115. And so then you see what our participation rate is based on the number eligible here, not the number referred. So we had about a 20% participation rate from folks that were eligible at that primary care well visit. And then the last thing we look at is representativeness. And you can look at this in a lot of different ways. We looked at it based on ethnicity, since we were in an area that had a fairly significant Latina population. And so we compared the proportion of Latinx folks in the study with the proportion that were in the catchment area. And we found that we were ethnically representative, which means it was the same proportion in our study as it was in the area. And then we were, is often with physical activity and obesity interventions, we were overrepresented with women. So women were more responsive to engaging. So that gives you a quick definition of reach and how you might operationalize that with a study that had some components of what exercise as medicine would look like. Effectiveness, I'm going to breeze through because I think everybody knows what it means to evaluate a program or policy or practice for effectiveness. It means, did you change your primary outcome? We also think about it from a REAIM perspective is, with that outcome, did you see concurrent changes in quality of life? And were there any potential negative outcomes that you wanted to measure? Here I'm using an example from some of our colleagues down the road at University of Nebraska Kearney. So Mark, there's a lot of University of Nebraskas. Actually, there's 4 of them. But at Kearney, they did some work with the public school system, and they used a policy implementation. And you can just see increases in minutes of activity after the policy implementation there. And so change in physical activity is a typical effectiveness outcome that we use within the REAIM framework when we're looking at physical activity and exercise interventions. So then we'll come to adoption. And this one's a little bit, we're shifting now from reach and effectiveness, which are measured at the patient level. Now we're shifting to organizational level, staff and organization. And so for adoption, we're really talking about the number, percent, and representativeness of settings and educators or staff that participate. Our example is one that we did a long time ago now, but Watt, Kansas, where we were trying to get a physical activity promotion program delivered through cooperative extension, which had folks that are similar to community health educators in each county within Kansas. And so we had 105 counties, which becomes our denominator. If we were thinking about this from a clinical perspective, that might be the number of clinics. And then within those clinics, you might think about the number of providers, right? So we'll talk through this a little bit more when I get into the examples for exercise as medicine. But for the definitional component here, you can see there's our denominator of settings. 48 of them agreed in the first year that we did the program, which was 46%. Then we looked at representativeness here. And one of the things we found was that the cooperative extension agents in those offices, if they were not physically active, they were much less likely to implement a physical activity program, even though it was a program that was designed to be highly scalable and not take a lot of expertise to implement. And then smaller population counties, in this case, were more likely to deliver the program. So that just gives you a sense of how we would look at it from a setting level rather than at an individual level. And then we get to implementation, and implementation is pretty simply defined the extent to which the program or policy is delivered consistently and the time and costs of the program. And so I say it's simple to define. It can be very complex to evaluate. As Robin was saying earlier, exercise as medicine is a systems-based approach that touches a lot of levels and a lot of components within a healthcare organization, a lot of departments. And because of that, it can take a lot of time and energy to get it started up and then implemented with some level of consistency. And so for us, we used iChoose, a program that we're just finishing up a comparative effectiveness trial on our second phase of this study, but it's a childhood obesity treatment program, and it was designed to be implemented by community leaders, so parks and recreation staff. So a little bit similar to how you might partner with external fitness facilities to have an evidence-based physical activity program that would be a place that you could refer patients to within exercise as medicine. And so for this one, we just simply looked at the proportion of the objectives achieved. So for this one, they had 6 bi-weekly family sessions, and we, since it was a research study, we actually had someone sit in the room and just kind of with checklist, hey, what did they do and what didn't they do? And so you can see they were pretty good at delivering the learning objectives for the family sessions. We also had bi-weekly telephone support calls, and you can see that the folks implementing those were had high fidelity to the protocol. And then we had exercise sessions, which was this 80 to 90% was the amount of time that was spent in moderate to vigorous physical activity during each of the sessions. And our goal was over 75%. So they were pretty good at doing that. So it gives you a sense of how you might look at implementation. It's going to be a little bit different when we get to the exercise as medicine component in a couple of minutes here. And then cost, we're still working on our cost, but we're looking across all the people and all the activities that they do to get iChoose in place and then sustained. And we'll again talk a little bit about cost later on. So now we're at the last re-aim dimension, and it actually has two levels. We still want to look at individuals with maintenance, and so it's really, do we sustain the positive outcomes in health that we see for our patients or participants? But then we also have an organizational level of maintenance. Are we able to sustain the program itself or the policy itself within a given setting? And so this is a nice paper by another one of my colleagues, David Jabultowski, who is looking at physical activity promotion in middle school children with the Healthy Youth Places project. And so when we think about the individual member, you can see basically he's looking at physical activity. I don't know if you can see my marker there, from 6th grade to 7th grade to 8th grade, based on different intervention groups. And you can see the physical activity intervention was effective from 6th to 7th grade, and then was even sustained in terms of increases in blocks of physical activity. And that was the primary outcome for that particular study. Oops, there's the definition, long-term effects and attrition for the individual member. And then when we think about maintenance at the organizational level, it's really the long-term sustainability of the intervention within that organizational setting. So once you've got it up and running, the implementation is typically considered, we think about implementation as the first run through, or with exercise as medicine, it could be an arbitrary period of time where you say, hey, we're going to do 6 months and see how we're doing on it. And then we would kick to maintenance to see, well, how long after that point in time is the system still in place? And so I'm not going to go through all of these, but you can see that when you look down at the bottom piece here, this just shows the number of counties that took on WAC Kansas when we first did it, and then increasing number of counties over time. But most importantly is once a county started implementing that physical activity intervention, they sustained it from year to year to year. And, we finished our study in 2006 on this, and WAC Kansas still goes, despite the fact that none of the people that designed or initially implemented it are there anymore. So it was a really nice success in integrating that into a system of cooperative extension in Kansas. Okay, so now we're on to why do we want to do this with exercise as medicine and using the re-aim framework? Hopefully it's pretty clear to you now. And I'm just looking at my watch because I want to make sure Mark wanted to have about half an hour's worth of questions. So I think we're pretty close to on track for that, Mark. But so the first thing that I think about the appropriateness for using the re-aim framework to evaluate exercise as medicine is that it allows you to focus on both the patient or the participant as well as the organization. And it gives you what I think are things that are going to be pretty telling for whether you're going to be able to have a large impact with the exercise as medicine approach or not. You can see it helps for the planning at the patient level, directs the attention to how can we integrate this so fully within the system, or how are we going to integrate this most efficiently within the system to make sure that we're reaching a large proportion of the patients that could benefit from this. And then at the organizational level, what are some of the things that by evaluating our adoption, implementation, and sustainability, it can give us some ideas about strategies that we might want to implement to improve those different outcomes. From, maybe there's certain clinics that aren't doing the brief counseling, that aren't doing referrals, that we might want to focus in on and see if there's additional implementation strategies that could help them adopt the system as well as then sustain it over time. And then, one of the things that it does too is it allows for composite metrics. And so and this is one we're not going to get into a ton today, but it's one that, I've always thought that the reach by effectiveness composite measure is a pretty important one. So we can have a really effective exercise as medicine solution. But if we're only getting, out of our 5,000 patient panel that could benefit, if we're only getting 50 people into that a year, looking at reach by effectiveness could tell us a little bit more than just looking at either one of those two things independently. Okay, so what I'm going to go through here is, I'm not sure how many people read the article that Mark sent out, but this presentation really is going to walk through some of the factors within that article. And then hopefully we're going to have some questions for people that want clarification or to dig deeper into this. So before I jump right into each one of the dimensions, one of the things that we thought about when we put that paper together was, what are some considerations that you would want to have before you actually even got started on this type of evaluation. And so we started from the point where, wouldn't it be great if we tried to focus evaluation on data that was already available to the health system, rather than trying to create a new place where people have to collect new information. We also really focused on this idea of stakeholder input and making sure that you're engaging the appropriate stakeholders within your system so that you understand what is it that they value from an outcome. One of our experiences, even though we'll go through implementation to a good degree here, is that assessing implementation fidelity oftentimes is not very moving for organizational decision makers and stakeholders. But it's important, if you're not getting the results that you want, it's important to understand, well, are you actually implementing the full system as it's intended to be implemented, or are the results that you're not getting the result of the fact that implementation isn't very good? So, there's kind of a balance between what, focusing on stakeholder value and then also doing things in a way that you're able to identify when you might need some quality improvement processes to fix that up. Related, obviously exercise as medicine is really integrated into electronic health record, but so are a lot of the health related outcomes. And so again, that kind of relies or relates back to the first point. And then, we've also thought about focusing on things that are within the clinic rather than, because as Robin said, part of the exercise as medicine approach is that you have these 3 steps, but then there's also an understanding that if you had a really good physical activity promotion network within your community with the YMCA or Parks and Recreation or some of these other places where they actually could be doing an evidence-based behavioral intervention to help people promote physical activity, that's going to make things a lot better for you from an outcome perspective. But it's really hard to try and evaluate that stuff from within the healthcare system. And so when we go through this, you'll see that I have some expanded indicators for REAIM that you could look at. But really, those expanded ones are typically kind of drifting you out into the community too, to see if you have the resources, this might be something that would be good to do as well. All right, let's see here. And yeah, I think that's good. We'll move it along. So now here's the recommendations for evaluation. So hopefully we're going to start getting some questions on this stuff here. So when we started thinking about REACH, we really thought about REACH from the standpoint of each of the 3 different things that Robin had mentioned before. So what are the number of patients that end up getting screened for their current physical activity level? What's the number of patients that actually received brief counseling and a physical activity prescription? And then what was the number of patients that were referred to a physical activity program? And then of course you see below there, and there are 2 number 3s, but that's not an accident because both of them are related to referral. But when you look at that, so once we get the number, we also want to look at the proportion. So what was our denominator of potentially eligible patients? And that's going to be based upon how you're using exercise as medicine. Are you using it for, any patient that comes in for any visit? Are you tying it to well visits? Are you tying it to chronic care visits? So your denominator might change based upon who your intended audience is if you're not using it across a full system. And then finally, we think about documenting representativeness across those 3 groups too. So, you could look at, here, where we're always trying to make sure that we're represented in Black participants, where we have a pretty good population within Omaha here. But in our research studies and programs, we tend to get a lower proportion of Black participants. So We look at that all the time. That's one of our representativeness keys. For you all, it could be something different. Obviously, we would recommend that you always look at demographics because a lot of health disparities are associated with demographic factors. And so making sure that you're getting the people in that could benefit most is important, or getting them screened, getting a prescription and some brief counseling, as well as getting them referred. It's really nice to be able to look at representativeness across each one of those steps. So again, I'm not going to spend much time on the expanded evaluation for REACH, but it would basically be looking at what I would call step 4, getting out into the community, or even if you have a clinical physical activity program, sometimes getting the information from them about the number of referred patients that actually engage and start the program can be challenging, but it's something that you could look at. And again, I would look at the number and proportion, and I'd also focus on representativeness here. Okay, so the group talked a lot about effectiveness and what would be a good way to evaluate the effectiveness of exercise as medicine. Me, I'm a public health person, so I think if we have a really good measure of physical activity, that's enough. But of course, we have other people that are in clinical settings and other stakeholders that think that, we might need more than that. And so the recommendations for effectiveness are to look at physical activity. And the proportion of folks that end up meeting physical activity guidelines as a result of being exposed to the exercise as medicine intervention. And then there's also a group of cardiometabolic biometric values that you could do in terms of body mass index, which we all know is not super sensitive if you're just doing a physical activity intervention, although sustainability of body mass index and weight is certainly a good outcome. But some of these other things are quite responsive to physical activity promotion. And so making sure that you could look at some of these over time. And again, I'm gonna hit this a few times, and that's in one of the concluding remarks too, is that all of this stuff is really important in terms of getting stakeholder input. What are the things that are valued? What do your physicians within your system believe would be, key metabolic outcomes or biometric values? Maybe some would say, well, HbA1c, if they're in a normal range, it's going to be hard for us to move any of that. So since we're doing this is a prevention approach, maybe we wouldn't do that one. But you never know, right? But stakeholder engagement is important. Again, these are all things that you could glean and pull from your electronic health record. And so you'd be able to do that in a fairly practical and pragmatic way. And then you could look at incidence of chronic disease burden or disease complications before and after the implementation of exercise as medicine and engagement or reach with those patients. So if you wanted to do some sort of expansion on this, and all of the stuff that I just listed on the previous slide for what a standard evaluation would be, it's not easy to get that. Like all of this stuff, there's levels of ease and difficulty depending on the system, what your analytics group is like within your health system. Some of the pull of the data could be really simple, but they still need to write the code for it. They still need to get that in place and up and running. These next level of things tend to be things that are more difficult to do. So healthcare utilization and cost. The utilization usually is fairly easy to get to. The costs, depending on how your billing data is integrated with the electronic health record, that can be more challenging. But obviously, looking at healthcare utilization and cost can help us to determine qualities of people that are exposed to the exercise as medicine approach, and we can actually look at cost effectiveness from that perspective. Another thing that the group thought would be important is to look at dose and how that dose is related to outcomes. All right, so now we're moving again to the organizational level. And so here you can see that we kind of group together providers and clinics. We know that adoption of this type of approach, because it's, there is some reliance on physicians, obviously to, screening can be done by electronic health record pretty simply before a patient even enters the room. But if we're going to do that brief counseling, and if it's the provider that's going to do that within your system, then there's going to be adoption at that provider level too, because not all providers will do it. And that's just kind of the nature of this type of work. But you can see again, you can look at different standards, and this is kind of where the work group came up with, was to say, well, you know, what proportion are screening greater than or equal to 50% of their patients for their current physical activity level? What proportion are reaching that 50% for the brief counseling for eligible patients, and what proportion are meeting that 50% of referring eligible folks to physical activity programming? And again, this 50%, we talked about it as a group and thought, hey, that would be kind of a nice marker, but this is something that again could be flexible, and you could decide within your system what is the way that you're going to assess adoption. And the nice thing about this is it can be kind of rounded up from clinician, and then clinicians within clinic, and then clinics within organization in terms of uptake. And then of course, once you get that number, we look at proportion. And again, this is a really nice way to be able to, in early evaluations, identify quickly where there's clinics and physicians that may not be jumping right into this. We know when we talk about diffusions of innovations that, you know, we have people, there's a small group that's going to jump right on this and do it. There's a larger group that's going to, you know, see what goes on with the first group, and then they're going to pick it up. And then there's another group that's going to really want to wait to see all the outcomes and everything before they do anything. And that's okay. But if you can increase the slope so that you're getting more people adopting on a faster basis, then you're going to have a higher likelihood of good program outcomes. And then again, representativeness here is a little bit different. And, you know, it could be, you know, I always think back to our Walk Kansas experience, where we found that if someone was an inactive cooperative extension agent, they were 13 times less likely to adopt a physical activity program. And so, you know, looking at different types of characteristics of providers can be pretty important here. And it could be things in terms of, you know, years of training, specialty, any types of factors that you'd like to put in there. Again, probably going to be driven by your stakeholder groups as to how you might look at representativeness. And so if we wanted to expand adoption, this one, again, it jumps us out into the community or into an internal physical activity program, and just looking at you know, if there are currently physical activity promotion programs within your city or within your catchment area, you know, have you partnered with those? And of those, how many of those have agreed to receive patients through the referral? And I would say if you contact them, almost all of them will be, because community organizations are always struggling with reach to fill programs. And so, you know, these can be really good partnerships. And then there's also, you know, this idea, and this is really challenging to do, and oftentimes it ends up being the researchers that are most interested in this, but we do get some organizational decision makers that are interested in the startup costs. And so you could look at what's the cost of just getting this adopted, just getting this up and running within the system. All right, we are rounding out, you guys. We're getting close to the end of these recommendations. So from implementation, this one was a trickier one for us to do, and I'm not going to talk through each one of these bullet points. I'll just let you be able to look through them yourselves. But the idea here is, you know, using each of the steps and then looking to see the degree to which those 3 steps are completed. And so, you know, is it 33%, 66%, or 100%? And then looking at that over time as well would be something that would be fairly straightforward for you to be able to do from, hopefully, from if this is integrated into the electronic health record. And then again, we have an expanded one that I won't spend a ton of time on, but you could look at costs again related to implementation in an ongoing way, as well as costs related to the community programming that's going on. Again, healthcare providers aren't going to be that interested in your costs for your clinic, for your community programming. But they might be interested in having some audits of a community program to ensure that they have high fidelity to an evidence-based physical activity approach. Okay, so for the standard for maintenance, at the patient level, it's pretty straightforward. It's just taking effectiveness and looking at it at some point in the future, whether it's 6 months, 12 months, 2 years, 5 years. That could, again, be set based upon what stakeholder interest is. And then at the institutional level, it's pretty simple too. It's just monitoring that implementation metric that we talked about and looking at that over time. So how do we do in the first 6 months from an implementation perspective, the first year, the first 2 years, the first 5 years? And then if you wanted to look at expansions, again, the expansions would be just expansions of the effectiveness ones looked at over time. And so moving away from the re-aim thing, one of the other things that we talked about was if you had internal referrals, what would be the standard evaluation there? And here, you know, we've already kind of hit it in some of our expanded metrics for organizations that don't have an internal program. But for those that do, you can assess your reach, your representativeness, your effectiveness and maintenance outcomes based upon people that actually engage in that program that you have internally. And then there's some expanded ones. You know, you could look at, again, dose just of the physical activity programming. Does the number of sessions that people attend impact their outcomes, which there's pretty good literature that would say that it does. And then you could also look at, you know, the degree to which you have high implementation quality at that internal program by doing, you know, kind of drop-in audits or those types of things, as well as the cost to implement the internal program. When we think about external programs, there's really no standard assessment there because it's really hard to get data from external partners. And I'm not saying it's impossible. And if you can do it, it's great. But if you can do it, here are some of the ideas that you could put forward for an expanded assessment, which is the same as the internal programs, but you're just trying to get it from someone that's not within your network or system. Okay, so I have flown through this as quickly as I can. Probably not as quickly as Mark wanted, but we will be ready for questions here. So, you know, the one thing that I wanted to say is that, you know, I think of re-aim as a fairly intuitive, easy to understand planning and evaluation approach, but it's still really complex to actually integrate into a complex intervention like exercise as medicine. The other thing I'd say is that not everything has to be assessed at all the time. And you know, as you're thinking about your evaluation is, you know, just think about when is the information needed and then develop your reporting criteria accordingly. And then the last thing, which I think I've touched on enough here, is that using a collaborative approach where you have your organizational decision makers and other stakeholders, that's going to help you to identify which of these outcomes are important and when. And by doing that, you can actually have a more pragmatic evaluation that lets you basically, you know, assess the things that are going to actually be meaningful within your particular system. And with that, I think that's it. That is it.
All right, Paul, thank you so much. That was fantastic. A reminder to everyone on the call that much of what Paul presented is in the paper he referenced early in these slides. This will be recorded and we'll post it all on the website so you can check up on some of the information there. Also, a lot of questions about the physical activity vital sign. Kind of as a next step in the RLC, we're thinking about getting on people who have done research using the physical activity vital sign so we can dive into that a little bit deeper. But now a couple of questions. And I actually want to start with Robin. Do you want to jump on and your call? Because I think it's kind of the beginning piece of what your point was, Robin, if you want to ask that question.
Sure, Paul. I wondered if you could share with the group your suggestions on how scientists who had an interest in doing this type of research may approach, you know, leaders and stakeholders in a healthcare system. And then on the reverse side, if you work within a healthcare system and you have an interest, but you don't have the research expertise, how might you look in your community and discuss or have an opportunity to discuss this with an academic institution?
Sure. So let's start with the academic folks trying to reach out to healthcare folks. And, my best tip for you is to start with whoever is directing population health management within the system. Those folks are very receptive to this type of work, and they also typically have some decision-making authority. So I'd start there. The other thing I'd say is for folks that are in the system, asking questions around about just trying to figure out who's interested in physical activity. And I guarantee you, you're going to find, in a healthcare system like Nebraska Medicine here that we work with, where, we have 17 clinics, it was pretty easy for me to pull together almost 12 to 15 physicians that were really excited about promoting physical activity. And so, looking for those folks within the organization that are champions for this type of thing can really be helpful. And I think the same thing for people that are external. Trying to identify champions can be a little bit tricky when you're outside of it. But one of the things that, we have here in Omaha is we have different community councils that focus on health within their communities that aren't typically run by academic institutions, but also typically have a health partner. Going to those types of meetings can help to get you connected with other people that are interested in physical activity promotion as well. So I think getting out into the community and interacting in forums where there's going to be healthcare represented.
All right, thank you. Great question. And building on that, Anne-Marie says, how is this received, this evaluation framework, and trying to get in with clinical providers? Is there interactive, meaningful feedback that benefits the individuals once data is shared with the clinical team?
Yeah, so, we didn't talk at all about how you might have feedback loops in this. But I would say that from a provider perspective, they're very interested in how many people from their group end up, participating in a program. They're very interested in outcomes. If they can get outcomes in an easy way, again, fed back to them. Using the health record is okay for that. Sometimes but for them, they're not going to go in and dig into an individual patient's record to see how they're doing and things like that. So there's usually some reporting piece that needs to be built that helps to put this out in front of the physician providers or clinical providers. But yeah, I would say that there's a range, to be very frank. There's a range of acceptability on this. Like, some are just, hey, great, I'll do a referral, but they're really not all that interested in seeing the reach data on their clinics. And then others are very interested in that type of thing. So it's going to be variable. Again, I would kind of move back to this idea of, the folks that are doing population health management, and as also, I guess I should throw out value-based care organizations, as we're getting more and more focus there. They're really interested in it from how can we use physical activity promotion. Prevention, yes, but they're even more interested in it from a secondary prevention standpoint for chronic disease populations. And so that might be a place where you'd get the first foothold if you're trying to engage with the system.
All right, and next, not to skip your question, Ken, I think we'll hold off on your question till the next meeting when I really want to dive deeper into how to look into the data and pull it out and analyze it. We got some great people on tap who've been doing that work, and hopefully you can contribute to that conversation. We'll go down to Coralie. She made a comment. Paul, maybe you want to chime in about quality improvement piece and how this could be used as part of a quality improvement effort.
Yeah, I mean, it's kind of funny because learning collaboratives, you guys starting a learning collaborative here, that those come from quality improvement. That's where a lot of that work initiated. So, I would say that if you're using this from a quality improvement perspective, it depends on what your outcome is that you're trying to improve quality around. But the idea would be that, I would think from a quality improvement perspective, typically what they're most interested in, again, is reach and effectiveness, right? And that's what the providers are going to be most interested in, but then the organizational management, they're going to be interested in that, but they're also going to be interested in adoption and implementation, maybe adoption more than implementation. What proportion of our clinics are doing this, and what proportion of the providers within the clinics are doing this. And so I think those things together are all things that can feed into a quality improvement loop where you have regular reporting out, and then you just build it within the existing quality improvement structure that you have. I don't know if that was a great answer, but that's my answer.
No problem, thank you. So there's a question about sedentary time as a vital sign. I'll start this one off because I've been part of the conversations. I think one of the initial blocks to not including sedentary time as part of this physical activity vital sign is that it doesn't have a measurable goal yet, national standard, like we know 150 minutes per week of moderate intensity activity. We don't have the same standards to compare it to. So if we ask people the amount of sedentary time or how long they're sitting in a day, and they say 8 hours or 6 hours, we don't have a measurable or a goal to achieve. Paul or Robin, would you like to comment on that further?
Nope. That's. But I did notice right above that she also asked if there was psychosocial components to it, and and I would say again, this is one of the things that depending on stakeholder interest, that you could integrate within it. I would say that they might be antecedents to effectiveness within a re-aim perspective. But yeah, I mean, I think that you could do that. I know a lot of healthcare organizations are now moving towards trying to capture patient-centered goals, so patient-reported goals, and then monitoring those goals over time, which, goal setting is a psychosocial component, but not too much more than that. I have heard of folks trying to maybe put in some self-efficacy types of assessments to see if they could, but not the way that we as scientists would think about, then tailoring intervention to the person. More focused on which people are we going to put resources to, and those that are more committed, we put the resources to. Those that are less, we might not. So there is some of that, Anne-Marie.
Okay, I'm gonna skip to Bob has a question about medical fitness centers and getting them in the referral loop. Paul, do you have any experience with that?
I don't.
Okay. Robin, would you like to comment? I know you've been working with the medical fitness centers.
Well, no, I mean, medical fitness centers already have an affiliation with the health system. And so they are, uniquely situated to engage in EIM type work. So I'd be interested to know if there are some research studies that have been conducted with medical fitness centers, some outcomes, and some of the markers that Dr. Estabrooks was talking about.
Yeah, I can certainly see the value there in looking at referral pathways to a medical fitness center versus referral pathways to the community setting and seeing if one works better than the other. What are your thoughts, Paul?
Sorry, Mark, I was reading the comments. You got to state your question.
Well, I think, Mark, to your point, I think with a medical fitness center, I think there's already a higher level of trust built in because they are affiliated, and they tend to have programs and staff that already, are very well qualified, and they're used to seeing these patients with common chronic conditions. So I think the job, at least my impression is, Bob could let us know, that the job of making those connections has to be much easier than if you're going out into the community where it's less of a known entity. And then it's more important to identify who can provide what's needed for the patients.
Yeah. And yeah, to me, it almost seems like it's a hybrid in between, having an internal program and trying to create a new connection with a community partner. But to me, it seems like it would be a great arrangement for the exercises medicine piece. And I did want to just, in a little bit different thing, because I don't know that Mark's going to read this one, Robert disagreed with me that providers don't care about the cost of community-based interventions. And when I see you write that, Robert, I would say I completely understand what you're saying, because providers definitely care about out-of-pocket costs for their people. They definitely care about that. They don't want to be sending somebody off to a program that's going to cost them a couple $100 and the patient not being able to. That side of it for sure. I just wanted to clarify more. What I was thinking is they're not necessarily interested in seeing cost as an indicator of effectiveness over time, that type of thing. So.
Thanks, Paul. You know, and I just want to add in a couple of shout outs here. Melody, sounds like you're doing a fantastic job at UConn, and maybe perhaps in the future we can have you on talking about how you've evaluated your EIM on campus program. And I can't stress enough what Paul's gone through here today is such a crux and so important. You know, working with health systems and governments that are doing this around the world, they'll come out and they'll say, we've referred 200 patients to community resources and they've improved 50%. And I go, but how many patients went through your system and how many providers participated? And the numbers come back, well, that's 0.001% of all patients and only 5% of our providers are participated. And so on the one hand, they're looking at the data with this, you know, we had this tremendous effectiveness in the people who participated, but it really just touched a small portion of the overall population. I think what Paul's talking about here is really so important to that. So let's finish off. Daniela, do you have any experience, Paul, about evaluation process of EIM in other countries?
Do I? Yes. We've looked at whether it was exercise as medicine specifically, we've looked at basically the same process: screening, brief counseling, and referral to treatment in Mexico. And, you know, and we haven't looked at effectiveness from a biometric standpoint, but we have looked at physical activity, and it does seem to work pretty well for physical activity promotion. In the clinical setting, it fits really well from an implementation standpoint, but the increases in physical activity weren't to the magnitude that they had hoped would be possible. And some of that could be related to the existence of community programs, where some clinics was great. There was kind of exercise sessions right within the clinic. Other clinics didn't have that, and it didn't seem to work as well. But I know that Mark's had a lot of experience internationally with exercise as medicine.
Yeah, well, and you know, I think one of the things when you start talking internationally is not all countries in developing countries or places have a fully electronic system. So when we start talking about it being a pragmatic type of evaluation process, for us, it's data mining our EMR. In other countries, there's still a lot of paper-based. So it really shifts how you're thinking about collecting that data, because it's a lot more intensive rather than putting some code into the computer. On the flip side, I will say that a lot of countries, like in Latin America, have these amazing physical activity networks, just amazing. In Colombia, we wrote a paper, they're touching 70,000, 100,000 people a year across every community. So that's a ready-made community-based physical activity referral resource. The thing that was amazing is that they're not getting the referrals from the health system. So I think there's tremendous opportunities in every country is different, but for this connection of patients from the clinical setting to the community setting. So Paul, any last thoughts here to close out our first presentation?
No, I think this was great questions. Thanks for having me, and I'm excited to see how the Learning Collaborative develops.
All right. Well, we will post the link on a webinar. We'll send it out via email to everyone. We also are going to have a short survey to see what your interests and needs are in the future. We had over 65 people on today. Thank you all for participating. And Paul, a huge thank you to you for being our first speaker and getting this started on a great note.
No problem. On the always exciting evaluation topic.
All right. Thank you, everyone. Have a great week.
Take care.